We'll now start with the first panel, which will be moderated by Trip Gulick, who is professor of medicine and the chief of the Division of Infectious Diseases at the Weill Cornell Medical College in New York City, and a very long friend of the forum.
So let's have the panelists introduce themselves, say where they're from and what they do. As Veronica told you, I'm Trip Gulick from Cornell. I am a clinical researcher and a clinician. David, let's start with you.
I'm David Burns, Division of AIDS, NIAID, and I was the medical officer for the IPREX trial.
I'm Rafi Landovitz from UCLA. I'm a clinician and clinician researcher, and we have been implementing post-exposure prophylaxis, and now we're in the process of attempting to implement pre-exposure prophylaxis in Los Angeles County.
I'm Charu Malik. I'm a medical officer at the FDA in the Division of Antiviral Products. By training, I am an infectious diseases physician.
Connie Kellum, University of Washington, and the principal investigator of the Partners PrEP study. I'm standing in for Jared Baton, who couldn't get in on a red-eye flight last night.
Homayun Tanlu. I am the Chief of Medicine for AIDS Healthcare Foundation in Los Angeles.
Good morning. I'm Cornelius Baker, and I'm the Senior Policy Advisor for the National Black Gay Men's Advocacy Coalition and Senior Communication Advisor and Project Director for the NIAID HIV Vaccine Research Education Initiative at FHI 360.
Okay, great. So we have a diverse panel, well represented from around the country. And this panel has been charged with considering what are the safety issues for PrEP. And I'll start just by saying that when we say safety, there are medical issues that we'll want to talk about, and there are behavioral issues. And in addition, there are risks to the person themselves that's taking the PrEP. And in addition, there may be risks to others, such as, for instance, for a woman who might be carrying a child, there might be risks to the child. There might be risks to partners in a discordant couple. There may be risks to family members or friends who are HIV infected, and there may be risks to the community as a whole. We may want to cover all of those. The other way to consider risks is both short-term risks, and we've just heard presentations from many studies which help us think about them, but there are also longer-term risks to the use of PrEP. So let me jump in. We have a list of suggested questions. And I'm going to start with the broadest one first. So let's do the 30,000-foot view of this. And the first question asks, or the second question, which I'm going to take first, are there specific safety concerns with regard to prescribing ARV to HIV uninfected individuals? And so, again, I'm going to start by answering that and saying, yes, there are. So let's consider medical issues first, and I'll turn to the panel and say we've already heard some presentations that talked about, and again, let's take a broad view of this, so not drug-specific just yet. But what are the concerns about medical safety issues for prescribing antiretroviral drugs to HIV-negative people? So who wants to jump in? Rafi, what's the number one on your list?
Obviously, we need to have a different threshold when otherwise healthy individuals are being prescribed antiretrovirals in a prevention context than we do for someone who has a disease which needs to be treated. I think that's something that we all take as a given. What I would like to modify that perspective with is the notion that if we are going to be targeting pre-exposure prophylaxis towards the highest risk communities, presumably other attempts at HIV prevention in these individuals and communities have met with suboptimal success already. So I'm not entirely sure that no toxicity is going to be necessary, and I don't think we're going to find an agent with no toxicity. Some level of toxicity is going to need to be acceptable because this is an extreme situation.
Okay, so let's take a step back. So the first thing I want to do is just identify what the medical risks are, and then I want to go back and consider what you say, which is question number one, which is how do the risks in an HIV-negative person, how are they different or how are they the same than giving the same drugs to HIV-infected people, which you've nicely already begun to comment on. So the number one on your list, as I heard you say, was side effects and toxicity. Okay. We already heard a presentation that drug resistance, of course, could be a medical issue. Are there other ones from a medical point of view? Cornelius.
I think it's a combination of certainly I think that if you look at the epidemic in the United States and where it's going, one of the issues that the trials certainly bring to light, and I think that Dr. Grant has mentioned this in not today's talk, but in other talks, is the need for us to know a little bit more about the impact of the drug in adolescent males in the United States. When we think about, the data that was shown and where the epidemic is growing fastest in the United States, in 48% increase among 13 to 29-year-old males, and black gay males, in the United States from 2006 to 2009. What is there biological difference in prescribing these in a 13-year-old boy versus a 45-year-old or 50-year-old? So, and what is the long-term consequence medically in that? And I think that we need studies with adolescents to tell us that.
Okay, thanks. So not only do we need to consider the study populations, and we've heard data presented on MSM, male heterosexuals, female heterosexuals, but Cornelius reminds us that adolescents would be an important group to study, and the specific toxicity or specific safety issue for that group might be developmental issues. Are there others? Yes, Homayun.
The issue will be that one of this medication has to be taken for a long time, and if we are talking until we have other effective measures, which currently we don't, such as a vaccine or other interventions, what are the long-term toxicity of this drug in a patient in a population which would not have been exposed to these toxicities? A young 20-year-old which would not have been facing bone density abnormalities or kidney problems or other issues. Given the fact, if you even consider it more, even the fact that the efficacy of the drug, total of the trial of the 40%. So I think we need to take a broader approach and look at the further on if we're going to give this drug to our individual, young people at 18 or 20 years old who are very at high risk of HIV infection at this point, and try to see what are we going to do to them in 10, 15 years.
So I think that's a good point. So we're not only identifying safety concerns, but all the data that we heard this morning, although nice to have that data, is relatively short term. And what are the longer term issues for safety? Connie?
Studies excluded pregnant women and breastfeeding women, and they're increasing number of data suggesting that pregnancy is a time of increased risk of HIV acquisition. That we clearly need data on the risk-benefit ratio to exposed infants, both exposed in utero and with breastfeeding. So I think that's a very high priority. And then I would also add that I think that given that in many parts of the world, adolescents are at highest risk. And if you look at the Capriso 4 data with a 9% incidence in women in their early 20s in the Durban area, we need to have much more data on renal and bone mineral density in young women, as well as Cornelius was saying, young men.
Okay, I had a couple other medical issues that I'll submit to you all. Distinct from side effects or toxicity are just metabolic effects themselves. So changes perhaps in lipids, for example, which might not be considered a toxicity but could be a long-term effect here. Hepatitis B flares for drugs that are active against hepatitis B could be an issue, and one of the distinctions between using ART in people who are infected versus not infected is that people who are not infected using it for PrEP may go on and off their therapies, as opposed to HIV-infected people who should constantly take their drugs. And another potential one that hasn't been talked about are drug-drug interactions with other drugs that people may be taking, either by prescription or recreationally. Are there others? Are there other medical safety issues to giving antiretrovirals to HIV-negative people that we haven't talked about? Rafi?
I just want to jump back to one that you had transiently mentioned earlier, and that's the resistance one. And I think we learned a lot from IPREX and now some additional information from TDF2 that people who are seroconverting unrecognized at the entrance to a PrEP administration or demonstration project do seem to get resistant to the components of Truvada, and therefore screening for that, even in those asymptomatic, would be a critical piece. And it's unclear what the right interval of follow-up to obviate need for that more sensitive testing ongoingly is going to be. And I think one could cogently argue at this point that one of the potential reasons more resistance might not have been seen in IPREX was the lack of regular adherence to the drug. And we don't know what's going to happen when people do adhere to it and may break through it.
So clearly using two drugs or one drug would predispose to the development of resistance. Two different scenarios that you're talking about. One is people entering the study who are in the midst of acute infection, and clearly people have thought carefully about this now. We can eliminate that problem if we test for acute infection. But then the other issue is how frequently do you test on study, and will people develop resistance in that scenario? So those are good points. Are there, and again, broad strokes, any other medical issues that come to mind in terms of safety? And then we'll change gears to go to behavioral. Okay, so the ones I heard so far are side effects and toxicity, drug resistance, developmental, including both adolescents and fetus, pregnancy, change in metabolic, hepatitis B, and drug-drug interactions. Anyone from the audience want to add to that list? Well, why don't you shout it out, Jeannie? What was it? Why don't you text me, because I can't read your handwriting. So the point was that depression should be something that we think of, and also that in terms of study populations, can you apply side effect profiles from African populations to U.S. populations and vice versa? Last comment, Ken. As a specific medical risk here, which I think also leads us nicely to begin to talk about behavioral risks. So what are the behavioral risks of administering PrEP to an HIV-negative population? And the number one we've heard commented on already is risk compensation. So who wants to talk about that? Rafi. I'm picking on you, Rafi.
That's okay. Let me start with risk compensation. I'm extremely concerned about risk compensation. Although all of the trials that we've heard about today have not demonstrated risk compensation, I would remind everyone that these are placebo-controlled trials where people are brought in at a regular interval and counseled repeatedly, not only that the efficacy of the active agent is not known, at least at the beginning of the conduct of these trials, but there is a not unreasonable chance that they may be receiving an inactive agent. They're also getting regular counseling for behavioral risk reduction as part and parcel and reinforcement of these programs of combination prevention. They're provided condoms. They're getting condom education. It's an extremely intensive, both for the participant and the site, intervention. And we have no idea what's going to happen when this is deployed in communities where efficacy has been demonstrated. There is not a placebo, and there is going to be certainly less intensive risk reduction counseling, if any. And there is a propensity among at least U.S. populations to want a pill to fix everything. And you know that when this is being disseminated, that at least in some populations, that's going to happen. And the analogy that I keep hearing from communities is, why would you wear suspenders to keep your pants up if you're wearing a belt? People are not going to use condoms if they think that this pill confers protection. So I think this is very real, and we need to monitor it extremely carefully.
Cornelius.
Yeah, I mean, I think that we not only should monitor it, but we should also be looking at how to avoid it. I think, there were 3 recent trials or studies that came out that I think are important for us to think about in this context. One, MMWR a couple of weeks ago that showed that poverty for heterosexuals is one of the highest, is the highest correlate for HIV infection across different populations. So as we're thinking about PrEP as agent, particularly in poor populations, what type of resources need to be invested in those populations to assure its success? There was a study that came out, I guess about a week and a half ago, that showed adherence for those who were HIV positive among young people under the age of 24 was very poor. And so we already know in the HIV positive population that adherence is low among young people. So how do we improve adherence and create better structures for that? I mean, we've done that in other populations before through directly observed therapy for drug-using populations that needed methadone and others, and we have to think about that with HIV. How do we create more effective adherence-based structures? And then lastly, we just saw a study that God, I'm blanking on that, but I'll come back to it. But I think that, the bottom line is that, we know that we're going to have some challenges where HIV, where we're going to need to deploy PrEP the most, among younger people, among poorer populations. And how can we use, for example, behavioral interventions and integrate them with clinical practice, so that, let's say, people get a 5-day supply and they have to go to a modified empowerment program where they have a support group once a week. They have to attend that support group in order to get their package of pills, and so looking at and learning from the studies and also from the interventions that we've already developed to how to create a full combination prevention package that includes behavioral interventions.
Let me take us back up a level and say what I'd like to do is see if there are any other specific behavioral safety issues that we should consider. These are good comments. Connie?
Well, I think in the light of efficacy data from heterosexual populations, there's going to be a real desire for couples to use this for periconception prevention, and before we probably have the data on safety, or as much data as we would like to have on safety to infants. So I think we have to be prepared that, we're hearing this in couples who were telling they were on the placebo arm, and as we disclose the efficacy results, people are saying, so can we stop using condoms so that we can have a baby now, because we've been trying to hold off during the study. Can I make one other comment?
Sure.
I think the other thing that's more broadly speaking across populations, I think that the challenge when you, take a very kind of public health perspective with PrEP is if you really want to have an impact, the challenge will be to target this to the people who truly are at highest risk. And so when we talk about condom migration and such, I think that in a sense, if we were really to have an impact, it would be to deliver it to people who have, for whatever reasons, not been able to use the tools we have, because they're the ones that are at highest risk for HIV acquisition. So I'm not sure it's so much about condom migration in some populations, but just can we even find the populations who really are at a 5 to 10% risk of HIV? And if we can, then I would say that's a success. And even if they start with low condom use over time, hopefully they'll get into a relationship with a provider, and maybe some of those behaviors will change. But I often hear the conversation where people are assuming they're starting with high condom use and they'll take the pill and not use it. But I think our biggest challenge is, can we get to people who are not already doing something but are at very high risk?
I would like to make a few comments, if I may. One is that, definitely besides that there will be engagement in the high-risk sexual behavior, and we are actually the one that have been saying belt and suspenders, just for records. We've been it is also, I'm surprised that even in the group that we are already accepting, PrEP as a tool, or that we're gonna promote without even having further discussion in terms of where we're gonna do it and where not, as a general tool. For example, deploying it to adolescents or deploying it to this or that group. I think Connie has an excellent point. PrEP is gonna have a role in a targeted, population where they would not be able to use condoms, or they are forced to not use condoms. They could be women in some cultural area. They would be men or transgender.
Let me stop you for a sec. So some of these issues are going to come up in the subsequent panels, and our panel is specifically charged with defining safety risks. So these points are great. I know they're going to come out later in the day. Am I hearing that there are other behavioral issues, risks to giving PrEP besides risk compensation, which is a big one, and conception issues? I'm struggling with how to incorporate adherence. It's an issue for PrEP, but it's not really a risk so much outside of the resistance part of things. Are there others from the panel? And then I'll ask the audience.
Well, I guess the other one that it's sort of one of our later topics on this particular safety panel, but the one of diversion of, in populations where treatment is not available to everyone who is HIV infected, is making it available to people who are uninfected, going to just encourage diversion of that drug actually to people who need treatment for their own infection.
Okay, definitely diversion should be on the list. Are there other ones from the audience? I'll take a couple. Risk perception. So that's interesting. Good point. Yes. So recreational drug use potentially. Yes. Risk of stigma and social harm in that someone identifies themselves as being at risk for HIV, and that's why they're presenting for PrEP. That's a good point.
Just an add-on to what Reggie said, I'm not just diversion to people who are HIV positive, but I can see some people wanting to share it with their partners, so I think that has implications both for the person who's been prescribed as well as the person.
Good. These are good. Okay, let me summarize then. The behavioral risks of PrEP that we've identified are risk compensation, issues surrounding conception and discordant couples, issues of adherence, diversion, both to and from HIV-infected people and to and from HIV-negative people, risk perception changes, and stigma. Did we leave anything out? Yes, Tim.
Especially with adolescents who may want to, they perceive they need protection. The whole issue of where their parents think or know they're doing it. How do you get a pharmaceutical product to an adolescent? And what's the age of majority and how do you deal with that?
So issues surrounding adolescents accessing this. Okay, panel. Now that we've identified a pretty good list of both the medical and behavioral risks of PrEP, how do these compare? Since this is focused on an HIV-negative population, how do they compare with an HIV-positive population, that risk list? Yes, Charu.
Okay. I think, we've talked about safety, and I think that just like I mentioned that we're not looking at safety in isolation. What we're trying to look at is the overall risk-benefit assessment of a particular product or of a particular product for a particular indication in a specific intended population. So I think one way to look at it, and in general, our approach towards risk-benefit assessment is very different for an ill population which has an active disease versus a healthy population. With regards to the context of oral PrEP, we're looking at a prophylaxis indication. This is going to be intended, again, for a healthy, otherwise healthy, HIV uninfected population, which is at high risk for HIV acquisition. So I think in terms of doing those kind of comparisons between HIV-infected patients versus a healthy population, I think, we have to carefully consider the safety profile and how that would affect or how that would apply to a healthy population. I think in general, a higher level of safety is preferred if a drug is going to be used in healthy subjects or healthy population. So, I mean, that's sort of the broad strokes general approach when you think about the different population groups.
So, panel, does everybody agree with that? The risk-benefit ratio is going to be different for something that's targeted at healthy people without an infection versus people with an infection, and also the fact that this is a prevention modality rather than a treatment modality. So what we heard is that the threshold for safety has to be higher. Any disagreement on that? Cornelius?
Not total disagreement. I mean, I think that the concept is obviously something that one would agree to, but if you have a young black male population where the HIV infection rate is 46%, there's very little distinction between the needs of that person who's HIV positive needing treatment and the needs of that person who's HIV negative needing to stay healthy. And especially when you consider that the HIV negative person is already engaging generally in lower risk behavior, but in a high prevalent background. And so this concept of benefit is heightened actually by being able to stay HIV free over the course. And certainly if you're assessing this drug at 15, and let's say you're only taking it to, you have a greater sense of efficacy through some sort of program, to use other prevention methods. Being HIV, having something that helps you to not have HIV from the age of 15 through your life to having HIV at 15 through your life is, the benefit is way here.
So you're saying something very provocative, which is that the risk-benefit ratio potentially for someone who is at high risk for HIV infection could approach that of someone who already has the infection with the same drugs. That's provocative. Panelists agree or disagree? Connie?
I would agree. I think when we started this study with serodiscordant couples, it was on the heels of doing a study of herpes suppression in the HIV positive partners. Sorry, I think it's echoing. Because we started talking to the HIV negative participants or members of couples, and they felt they had absolutely nothing to other than condoms. If they wanted to stay with that partner, and fertility is an important part of being a couple, it was very limited in terms of what their real options are. So I think when particularly in a setting where you know that your partner is positive and you're living in settings where they cannot get treatment and you have children that you want to protect, I think this notion of benefit needs to be thought in terms of what it means in that person's life, be it as a young gay man at very high risk or in a couple where you're committed to a partnership, have children, and a little GI intolerance or a small change in bone density may be something that you're very well willing to take if it means that you can stay healthy and keep your family healthy.
Other panelists want to ring in on that? David?
Well, I think we do need to acknowledge as well that there will be persons who may be attracted to taking PrEP who, in fact, are at very low risk of becoming infected. And in that group, obviously you would not want to subject them to the risks of PrEP. And therefore, it's going to be a challenge to providers to individualize, to assess the true level of risk. And as has already been stated, that involves not just the individual risk, but also prevalence in their social network.
Well, that's a really important point, too. So the worried well will be coming forth to ask for this intervention. And how does an individual physician, who may not even be familiar with the drugs, which we're going to talk about later on today, make a decision about what's appropriate for that person. That is a big challenge. Comment from the audience?
I agree with Cornelius's comment completely if it's a population where people are accurately perceiving their risk. But if it's a population that for whatever reason is not making use of the other prevention tools we already have out there, then perhaps they're not accurately perceiving their risk and what would be attractive about perhaps having some side effects on, a regimen where they may already feel healthy and they don't see themselves as being at any increased risk.
Right, so challenges for the person themselves, what's their risk, and challenges for the person writing the prescription. One more comment?
Also for that worried well person or the individual who's coming in, we've had experiences where someone will come in and ask for pre-exposure prophylaxis and they've never been tested. So it's a great opportunity, if you've got the background and education provided to your providers, to use this to bring in people who are worried well, who may be at moderate or lower risk, but get them the education and the information that they really need rather than the pill.
So a great point, and I'm going to challenge panels later in the day to say, and who's the physician that is trained to do this? Which I think is a whole nother set of issues. Okay. Let's go back to medical risk. The number one we identified were side effects and toxicity, and we've talked about this. So we talked in general terms. We have to acknowledge that all the studies that we've seen so far have either been with tenofovir, with or without emtricitabine or FTC, and there have not been additional PrEP studies. So we have specific side effect profile in the populations that have been studied that we've heard so far. And some of the things that were commented by our speakers earlier in the day from their studies, GI side effects, nausea, vomiting, diarrhea, at least one or two of the studies showed statistical differences between those. Creatinine elevations were commented by several. Decreased weight in the IPREX study. Bone mineral density changes were commented on by a number of people. So now we're being more drug specific. But panelists, how do we assess these as a group in terms of side effects? Obviously not all the same in terms of importance or medical seriousness, can I say? Maybe not. I don't know. How do we assess that when giving it to an HIV negative person? Do we have the complete information? Cornelius says no.
What I mean by that is, I'm very well, first let me state a bias, and obviously as an HIV positive person, the bias has to be weighed, that I take a triplet every night, and I certainly understand the challenges of the side effects. But I also certainly understand the challenges of being a black male, and I understand the challenges that people exhibit in poor places and their health challenges just to stay alive. And so I guess what I weigh is, there are a host of conditions that people face in their struggle to survive. And I don't want to minimalize the side effects of HIV, but I do want to put them in a context of all the other things that threaten their lives every single day. And I don't want to overstate, diarrhea versus being shot. And so, I guess I just wonder what we weigh it against. And we're in a country where we don't even collect the basic health data about gay men. So we don't know what the generalized risk for them are. And so we have this one small element in which we know that HIV, particularly for young black males, is a significant and serious threat. We have very little understanding of the other health contexts in which they live. And yet we're trying to balance what this one group of toxicities have in comparison to everything else without any evidence. And so I guess I'm just a little, I guess I wonder how we weigh the value.
Well, one benefit we do have is that the studies that we heard were controlled trials, and so one group got placebo, so both groups are experiencing the same life at the same time, plus minus the active drugs. What I was trying to say a minute ago was the GI side effects captured on clinical trials can be quite challenging to interpret. So a single episode of nausea, which 27% of you have right now, would be checked off on the case report form and carried over and reported on that arm of the study for the rest of the study. So GI side effects, as we heard, well characterized on several of the trials, were that they were relatively acute and resolved over time. Other toxicities are more long-term. Creatinine elevations, bone mineral density changes. We focused a lot on those two, and again acknowledging that the length of the follow-up that we have on the current studies is relatively short, and there's a potential for cumulative toxicity over time that we may not have the information for. Again, many of the studies are going into an open label phase, which will be better characterizing those. But so, what do we know, Connie?
I guess I feel that we know quite a bit. There's always more you'd like to know. I'd like to know in settings where hypertension is prevalent, whether or not we would see more renal toxicity. But I feel like we can know those in relatively short order. And none of the either laboratory or clinical events that have been very carefully charted, as you point out, in clinical trials really concern me that much. I mean, I think the startup syndrome that was seen in IPREX, I mean, it was still a very small minority of participants, and all the studies have seen the same thing, that if it was reported at all, it was gone within a month, was not so intolerable that people stopped drugs. So I think we can counsel people about this, what to expect, just as we should be doing when we start any medications, but admittedly are not always so good at doing that. But I think we can prepare people for a small amount of GI discomfort, and I think that if they're motivated enough to take PrEP, that should not be a rate-limiting thing. And I think we can design in our open-label studies additional follow-up on loosen the eligibility a little bit so that people who do have other comorbidities, that we can understand more about whether the safety signal is any different in them.
So again, I think, Connie, you were provocative here. You said, giving a look at all the data that we saw this morning, that the safety issues are, I think you said, not of great concern or reassuring. Panelists, everybody agree with that? Rafi doesn't agree.
I'm not sure that I agree or don't agree. I do think what's important to look at is whether the acute toxicities in a way caused people to discontinue the treatment. And that I think is a signal to us about some of these things. The longer term toxicities and perhaps the more subtle toxicities, I think those can be more sinister. But I think get to the point many of us are asking, which is what's appropriate risk to make those toxicities worth chancing? And then perhaps more importantly, what's the exit strategy from PrEP? We talk about people may be on this for long, long periods of time. I mean, you're not going to put someone on PrEP for perpetuity. What other interventions are we partnering with this to get people off it so they're less at risk for those longer term toxicities? And I know some of that may not be our charge in this panel, but it sort of does sort of temper that question of longer term safety.
Two other points to make. Again, I spoke of this earlier, but PrEP is likely to be used episodically by people, and it may be start and stop. So the side effect profile may be different than what we see in HIV-infected people. If this GI toxicity is only associated with the first couple weeks of it, but you stop and then go back on, you may experience it again, I suppose. One interesting thing I thought about the bone mineral density, two things actually. One is that there was less of a reduction in bone mineral density in this population than in HIV positives, for reasons that aren't crystal clear. And the second is that it seems to stabilize after some period of time and continue at that level. So it doesn't continue to decrease. And I'm not a bonehead. Maybe we have boneheads here who can help explain that. Michael, you're a bonehead?
No. Well, yes, but not in that way you meant.
Did you want to comment on that, bone mineral density?
No, but I did actually want to challenge Celia's statement. I think we're moving from a discussion of efficacy to effectiveness. And in effectiveness, you get a much greater range of discussion. So what's a grade 1 toxicity like diarrhea doesn't sound impressive on the manuscript page, but to the patient with diarrhea, even just intermittently, it can have a significant effect, even if just grade 1. And, we know that, look at diabetics. We have a hard enough time getting them to take their insulin, but then when you try to convince them to take the statin every day for an LDL of 102, 104, because we know we're supposed to get underneath 100, because the efficacy data shows clinically significantly saved events, it's still very hard to get them to do that. And I think we're really moving that more and more into this issue, that adherence will be probably the biggest driver of the issue going forward.
Yes. Can you raise your hand because they'll get you the microphone? There you go.
For adolescents, bone closure, epiphyseal closure doesn't occur, or full bone maturation doesn't occur until about early 20s. Particularly for young women on depot, which has been demonstrated to show decrease in bone mineral densities. What would be the effect of co-formulated TDF and 3TC on that? On women, on young women particularly, who are on depot and are receiving the drug. So it is an issue that needs to be studied.
Okay.
I'd like to ask a question maybe of Connie about the episodic use, because I think that this is an area of potential risk that I'm not sure that I understand. I just heard data this week that I was actually surprised by at the National HIV Prevention Conference, but because I think that, we've had studies that show that folks believe that they're less at risk in their primary relationship. Also, just presumptions like the Hopkins study earlier this year that showed young gay men judging the masculinity of their partner in terms of their risk. So I'm just wondering in terms of how we might view episodic use, that when people are in what they believe is a primary relationship, they might consider stopping during those points, and it actually might put them at greater risk. I think in the 052, where you showed that the partners, the persons who became infected, I think a majority of them did not become infected by their partner, but by someone else. So I'm just wondering how we might view sort of what are the conditions of episodic use and how much risk does that actually pose to us?
Connie, you want to take that on?
It's a really important question. I think the 052 study found something very similar to what we found in our partners herpes study, that about 30% of infections were found through molecular virology to be coming from a different partner. At least in our analysis from the herpes study, in these serodiscordant couples, it's not completely clear that it's concurrent partnerships, but actually that partnerships change, and that one of the challenges is that people don't take the same level of precaution with condom use if they don't know their partner's serostatus. So here you have a serodiscordant couple, the negative partner, typically the men have more outside partners, and did not use condoms with their new female partners, and they were not still having sex with their primary partner, had a new partner, didn't know their status, didn't use condoms, and became infected. So I think it is an issue for serodiscordant couples. It's one of the reasons why treating the positive partner will not prevent all transmissions in even so-called stable couples, because partnerships change and people have to go through that same whole process of getting their partner tested, going through the establishing trust in a new partnership. Episodic use, I think, is going to be one of the hardest things for providers to counsel about, because it probably will happen. Even within stable partnerships, risk is somewhat episodic in terms of if they're trying to conceive or not, at least within heterosexual couples. And I think that we're going to have to be prepared for what our messaging is going to be. At this point in time, I would encourage people to use a drug daily. If they're going to use it for an episodic period of time, that they should not be using it as the morning before pill. But that is, I think, something where we don't have enough data on, based on the PK/PD, to really adequately address questions or to anticipate how people may be actually using it on weekends only, for example.
So clearly an active area of research right now to try to define episodic use and if it's reasonable. Okay, let's take a deep breath here and see how we're doing on our questions. So we have actually commented on a lot of areas. We spoke about the medical risks of ARV prevention, came up with a reasonable list of them. And how does that compare to the risks for treatment? Meaning, how do we assess risk in giving ARVs as a preventative to an HIV negative person versus as a treatment to an HIV positive person? We talked about some specific safety concerns. We talked about an increase in or a change in behavioral risk compensation. We mentioned STDs briefly as a potential medical risk of PrEP in that context. We just talked about intermittent use. We talked about resistance. Is acute infection a concern? Yes, I think the panel agreed that it was. How can acute infection be detected in real-world settings? That's one we haven't tackled. So how are we going to do that? They're all avoiding my eyes. Connie, you're about to say it, I can tell.
Well, it's hard for me to sometimes extract myself from the places where we did the trials. In many parts of Africa, you're not going to be doing P24 antigen testing and PCR testing. It's just not available. So I think that it's more likely that you'll have to rely on symptoms and just have a very broad net of any viral-like symptoms that you would wait to start PrEP until they came in a month later and repeated testing.
So in resource-limited settings, we're going to be forced to use clinical assessment of acute infection.
For now, I think maybe that will change in terms of availability of antigen and PCR testing, but right now it would not be practical.
And in resource-rich countries, such as what used to be our own?
Well, I guess I recognize it's a risk, but when you look at the denominator, how many people were enrolled, like in IPREX, for an example, I'm not sure that everyone who goes on PrEP needs to have a PCR or P24 antigen testing. So it would be, from a guidelines perspective, it's probably easier to just say that, but I don't think it's very cost effective. However, I also recognize, and this we'll get into this, I think, more during the day, is that if we ask providers to do too much in terms of a detailed risk assessment that would guide whether or not they had recent risk and should get a PCR or P24 antigen testing, that adds more burden to the provider. So I don't know, I'd like to see some cost modeling on if you have 3% chance that someone you're starting PrEP on is in acute infection, is it useful to do that? Is it cost effective or not?
Wow, that's provocative too. So Connie's suggesting maybe we don't have to test every person coming in the U.S. for PrEP for acute infection. Panelists, anyone want to take her on? David.
Well, I certainly think that providers would, in general, prefer to err on the side of testing, and I think where an HIV RNA test is available, providers will want to assess very carefully and consider whether to do a test before possibly beginning PrEP.
And certainly the CDC guidance recommended that it be done as well. Connie.
I think there's an alternate approach where you could consider, I mean, again, I think it requires a little more data perhaps and some more cost effectiveness work, but another approach is that you could have someone come back a month later and if you had 2 negative tests a month apart, which gives someone a little bit of time to think about, are they really ready to start taking a pill a day? There may be alternative approaches. I mean, I'm not sure. When I've tried to bring up PrEP in my HIV panel, where people have a known negative partner. I'm going to bet that in many cases people are not going to make a decision that day. And so I think there are situations where you could start the discussion, do an antibody test. If it's negative and the next one's they come back in 3 or 4 weeks and it's negative, that you could start.
So is PrEP ever urgent or emergent? That big party that you're going to go to this weekend? Now, would anyone see PrEP as an emergent or urgent? Yeah, it's called PEP, right?
I think it is worth just mentioning, though, that, I mean, for people who are at the highest risk, whom we're going to be targeting this towards, a lot of risk can happen in that intervening month also. So I agree that for some situations that might be a more cost-effective way to approach it. But presumably, Bob can tell us, these 10 participants who enrolled in IPREX undetected and were acutely seroconverting, it's because they were asymptomatic, that they were not caught at the time. No?
Actually, the majority were symptomatic. They had viral syndromes that were non-specific for HIV, sinusitis, laryngitis, headache, fever without any of the stigmata that are specific for HIV. So actually 50% had viral syndrome.
So an acutely ill person should not start PrEP. Can we agree on that?
Yeah, well, that was what we ended up advising our sites when we saw this pattern occurring, people enrolling with what seemed like a flu-like illness. And it didn't help that we were enrolling during the swine flu epidemic. But I think we were able to be very clear that regardless of whether it's swine flu or acute HIV, this is not the right moment to be starting PrEP. And that, I think, helps. Other signs and symptoms of acute HIV infection are leukopenia, and oftentimes HIV acute viral syndrome occurred 1 week after starting PrEP, and the person came back to the clinic seeking medical attention for their acute viral syndrome. I think that is an opportunity to do but I think, is PrEP emergent? I think if there is an acute exposure, you have the option of starting a 3-drug PEP regimen and continuing that for 28 days. And after that 28-day period, consider either stopping it or switching over to a PEP regimen.
Okay, we have about 10 minutes left on the panel, and this is the time. I've had people speaking up from the audience, but I'm happy to take some comments from the audience. I have a bundle of questions. May I suggest that people not write novels on these with footnotes? Thank you very much. So comments from the audience about anything that we've talked about. Philippe. Oh, sorry. I'm sorry.
I was just going to mention that I'm not sure that it's emergencies that we're concerned about, but missing an opportunity. There's something that brought that patient in to have that discussion, or something that happened that caused the subject to come up, and then having a strategy that postpones it for a month may mean that person is lost to follow up or something like that, or ends up somewhere else. And so, I think the emergency really is that we've got the patient in front of us right now. Let's, if they're willing to have a plan that says, yes, I'm going to start in a month, that's great. But there's a lot of people that would be difficult for them to accept. There's something about where they are right now that means they need to do something positive right now.
That's a great point. So anyone presenting for PrEP is almost by definition at risk. Deborah made the point that we could test them for HIV right then and there, and also that they've actually come into the healthcare system, which is a good thing. Philippe's right behind you.
I was just thinking that maybe we shouldn't lose sight of the FemPrep study, because if it's not just about pure odd that it didn't show any benefit, then maybe there's some population where PrEP is really of no benefit, and any safety issue for that population would be a real issue.
That's provocative, too. Luke, do you want to comment on that?
anything which seems like a viral syndrome that you're having, because there is flu, there is malaria, there is common cold, there is a lot of things.
Okay, again, I think a lot of these issues are going to be brought up in the panels in the afternoon rather than right now.
Trip, can I just respond to one thing that was said?
Sure.
And it also goes back to this issue earlier about this concept of the worried well. I'm very concerned about how we treat that. There was a period that many of us in the room will recall in the 90s where we talked about the worried well who were coming in for testing and utilizing the HIV testing services, and actually as though they were abusive of it, especially gay men. And they were coming in 2 or 3 times a year to get tested, and we termed them the worried well. Well, today the recommendation is that gay men get tested 2 or 3 times a year. And so I think people have an understanding of their fundamental risk. And quite frankly, their healthcare providers often don't. And aren't very good at talking to them about them. So I'm a little bit concerned about how risk is evaluated, whether it's the individual who does it or the healthcare system that does it. And this is not only true for gay men, but also for women. And so I just think that we need to be careful about, and Bob has talked about the concept of risk before in a lot of provocative ways, but I just want to caution us around that.
Okay, I think that's a good point. Comments over here?
Thank you. I guess it builds on this issue of risk, and that is the gentleman over there said that if someone presents asking for PrEP, by definition, they're at risk. And I think we don't know. There's an internal calculus that people go through. There's perception of risk and then actual risk, which may or may not be actually that well matched. And then there's a dynamism to this whole risk perception, actual risk, etc. So I think that if someone presents requesting PrEP, there's certainly an educational opportunity there for all sorts of things. Whether they necessarily are actually at really high risk, I don't know that we know that actually. And I think this is true for populations of women in other places. And so I don't know where we fall on that, but I guess when we look at all of the work on PrEP, I think adherence has so much to do with this, particularly with populations of women in developing countries and elsewhere, I guess. But, what do we know about how well do you actually have to adhere, really, to actually get some use effectiveness? Because I think the reality is people will use it in all sorts of different ways. And what do we know and what do we get from that? Because again, their perception of risk will change, their actual levels of risk will change, and it's not linear and nice and tidy. So.
Right. I think those are good points. We'll take 2 last comments and then we'll wrap up.
The components of it have been mentioned, but as a social worker in the room, I just want to toss out language, biopsychosocial. And I think that this is a biopsychosocial intervention, and those having all those components from the beginning is absolutely essential to success. And following up on the previous speaker, we always say when asked the right questions in the right ways by the right people actually have the answers for their lives. And so part of this is also just ensuring that we're asking the right questions.
Charles, last comment from the great state of New York.
Thank you. Again, in terms of risk, my question is that about 40 years ago, we didn't think women could ascertain their risk or decide on whether or not they could take birth control pills. And I think that as a model of how we treat adults who are adults on their ongoing risk is a reasonable one, because it's not, as been mentioned before, risk is not linear, and it is episodic, and that as healthcare professionals, we need to be able to open up and be able to change what we prescribe at different points in people's lives. But also within this is also Where does this PrEP fall in the famous toolkit? Is it 1? Is it 2? Is it 3? Or does it shift up and down? And we don't know that yet, and we don't know how to do that yet. And that discussion needs to be done.
Okay, so panel number 1, our goal was to review what the safety issues are for using PrEP. And we spent a long time identifying the list of medical safety issues and also behavioral safety issues. And I think we all agree there are unique issues to this population. Also unique is how you balance the risk and benefit of these interventions, and we went into some detail about that. The data we have are helpful but incomplete, relatively short term. Lots of comments about what's the relevant study population, and we heard in particular that 2 groups that might actually use PrEP quite frequently, adolescents and women of childbearing potential, we may have incomplete information and need more. So all in all, I guess it's fair to say that debating the risk-benefit ratios for different groups is part of what we're here today. And people launched into many other discussions that I hope we will address in the later panels. So I'd like to thank the group. We're almost right on time, Veronica, wherever you are. And we're going to take a break now for 15 minutes, and we'll reconvene at 1:15. And is there coffee or something? Coffee is available either PO or sub-Q.